Hi and welcome to OneMedicine. This is second part in Rheumatology and Immunology lecture series. The next topic is systemic lupus erythematosus, or SLE in short. So this is a disease of unknown etiology in which the tissues undergo damage mediated by tissue binding antibodies and immune complexes. Genetic, environmental, and hormonal factors are implicated in development of the disease. T and B cell hyperactivity, production of antibodies with specificity for nuclear antigenic determinants, and abnormalities of T cells are seen within the disease. Let's look at the clinical manifestations. Approximately 90% of the cases are women of reproductive age group, with highest prevalence seen in Afro-Caribbean and African American women. The disease is characterized by periods of exacerbation and relative quiet intervals or symptom-free intervals, and can virtually involve any organ system. Some of the common features include constitutional symptoms, including fatigue, fever, malaise, and weight loss. Cutaneous symptoms, including butterfly or malar rash, photosensitivity, vasculitis, alopecia, and even oral ulcers. Arthritis in SLE is usually inflammatory, symmetric, and mainly non-erosive arthritis. Hematologic manifestations include anemia, which can be hemolytic, neutropenia, thrombocytopenia, lymphadenopathy, splenomegaly, venous or even arterial thrombus. Cardiopulmonary manifestations include pleuritis, pericarditis, myocarditis, endocarditis, and there can be accelerated atherosclerosis, which can lead to increased risk of myocardial infarction in these patients. Renal manifestations include nephritis. Gastrointestinal manifestations include peritonitis and vasculitis. CNS manifestations include organic brain conditions, seizures, psychosis, and cerebritis. Now let's look at drug-induced lupus. This is a condition where a clinical and immunological picture is similar to spontaneous systemic lupus erythematosus but induced by drugs. Some of the medications implicated in development of drug-induced lupus include procainamide, hydralazine, isoniazid, chlorpromazine, methyl dopa, minocycline, and tumor necrosis factor inhibitors. Clinical features are mainly arthritis, pleuropericarditis, CNS and renal diseases are rare in drug-induced lupus. These patients show anti-nuclear antibody positivity with antihistones being positive, whereas anti-dsDNA and hypocomplementemia are very rare in drug-induced lupus as against spontaneous systemic lupus erythematosus. Evaluation of systemic lupus erythematosus involves history and physical examination. Patients have a classical anti-nuclear antibody positivity, but the anti-nuclear antibody by itself is not specific to SLE. Analysis of ANA subtypes give a better understanding about the diagnosis of SLE, and some of the positive anti-nuclear antibodies include anti-dsDNA antibody, anti-histone antibody, anti-ssDNA antibody, anti-Smith antibody, anti-Rho or SSA, and anti-La or SSB antibodies. Patients may also exhibit elevated erythrocyte sedimentation rate and C-reactive protein levels, and patients will have reduced complement, that is hypocomplementemia, which is assessed by C3 and C4 levels. Patients can also have VDRL positivity, can also show anti-cardiolipin antibody positivity, lupus anticoagulant. If renal function is deteriorating, then patient can be subjected to renal biopsy for histopath classification. Now let's look at the treatment for SLE. The choice of therapy is dependent on disease severity, organ involvement, and stage of the disease. In general, the goals of therapy include control of acute or severe disease and development of maintenance strategies to provide a long-term disease suppression to acceptable levels. These treatment decisions are mainly based on whether the disease is life-threatening or is causing organ damage. If the disease process is reversible, and the best approach to prevent complications of the disease and therapy. As the disease mainly occurs in reproductive age group in women, the potential for teratogenicity and its associated counseling and contraception should be assessed on case-by-case basis. In treatment of non-life-threatening disease, a conservative approach is taken. This includes sun protection, as UV radiation from sun can trigger the cutaneous and even systemic SLE symptoms, and hence sunscreen is used. NSAIDs are used in the treatment of arthritis, but GI, cardiovascular and renal complications must be taken into consideration before prescribing NSAIDs. Anti-malarials such as hydroxychloroquine may improve constitutional, systemic and cutaneous symptoms. It can also alleviate arthritis pain in patients. However, ocular assessment must be performed before initiating anti-malarial agents, and patients should be subjected to regular ocular examination at frequent intervals. Methotrexate is considered in patients with dermatitis and arthritis. Belimumab, which is a B lymphocyte stimulator specific inhibitor, is used in patients with mild to moderately severe SLE and is usually avoided in patients with nephritic and cardiovascular manifestations. Baricitinib, which is a oral JAK1 and JAK2 inhibitor, is found to be effective for rash and arthritis in SLE. Treatment for life-threatening forms of SLE include systemic glucocorticoids, cytotoxic and immunosuppressive agents, which are add-on therapies along with systemic glucocorticoids. These include cyclophosphamide, which can be given as intermittent IV or daily oral medications. Two regimens have been studied. The first one being high dose cyclophosphamide regimen, where cyclophosphamide in the range of 500 to 1000 milligram per meter square of body surface area is used to treat severe systemic lupus erythematosus or severe nephritis associated with SLE. A second low dose of 500 milligrams of cyclophosphamide given 2 weekly for a total of 6 doses is found to be effective. An important thing to note here is after cyclophosphamide therapy, patients require a maintenance medication with azathioprine or mycophenolate mofetil. The other cytotoxic therapies include mycophenolate mofetil and mycophenolate sodium. An important thing to notice, higher proportion of African American women respond to mycophenolate compared to cyclophosphamide. However, patients on mycophenolate are at higher risk for teratogenicity, and effective contraception and counseling is provided for patients who are being initiated on mycophenolate. Azathioprine is found to be effective in managing the disease. However, it has a delayed response, especially in induction. Rituximab, which is an anti-CD20 B cell depleting monoclonal antibody, has controversial results in studies, and it is usually restricted to patients who do not respond to standard therapies. The next topic is rheumatoid arthritis. This is a chronic multi-systemic disease of unknown etiology, which is characterized by persistent synovitis that is inflammatory. The joints involved are usually peripheral joints and symmetrically involved. The disease course in rheumatoid arthritis is variable, but patients tend to have cartilaginous destruction, bony erosion, and joint deformity. HLA-DR4 association is noted. Rheumatoid arthritis in general is a immunological disease where the joint injury happens due to synovial hyperplasia. In this disease, the joint injury occurs mainly due to these factors, including synovial hyperplasia, synovial infiltration by lymphocytes, and local production of cytokines by activated lymphocytes and fibroblasts. Rheumatoid arthritis is one of the most common immunological disease and affects approximately 0.5 to 1% of population. The incidence is more in females than males, with a ratio of 2 to 3 is to 1. For every 2 to 3 female, there is 1 male with RA disease. The incidence of rheumatoid arthritis increases from the age of 25 to 55 years and plateaus from 55 years till 75 years, and then it reduces. So if we plot the graph of incidence, it looks something like this. This is 25, 55, 75, and then the age continues. The incidence slowly increases from 25 to 55 and plateaus until 75 and then comes down. Clinical features can be broadly classified into articular manifestations and extra articular manifestations. Articular manifestations include symmetrical polyarthritis involving peripheral joints Features include pain, tenderness, and swelling of affected joints. Patients can have classical morning stiffness associated with these joints. The most commonly involved peripheral joints include proximal interpharyngeal joints and metacarpopharyngeal joints. And surprisingly, distal interpharyngeal joints are usually spared. Chronic complications include deformities and joint erosions. Extra-articular manifestations can be cutaneous, where there can be nodules called rheumatoid nodules, or even vasculitis. It can be pulmonary with pulmonary nodules, interstitial disease, bronchiolitis obliterans organizing pneumonia, or BOOP in short, pleural disease, Kaplan syndrome, which is rheumatoid arthritis associated with pneumoconiosis. Ocular manifestations include keratoconjunctivitis, sicca, scleritis, and episcleritis. Hematologic includes anemia of chronic disease, Felty's syndrome, which includes splenomegaly and neutropenia. Cardiac manifestations include pericarditis and myocarditis. Neurologic can be myelopathic diseases, especially when cervical and other spinal segments are involved. There can be entrapment vasculitis. Let's look at some of the associated conditions of rheumatoid arthritis. Cardiovascular diseases are the most common cause of death in cases of rheumatoid arthritis. Osteoporosis is more common in patients with rheumatoid arthritis than in normal population. Hypoandrogenism, which is documented by decreased testosterone, luteinizing hormone, and DHEA levels. Patients with rheumatoid arthritis are at increased risk of lymphoma, where there is a 2 to 4 fold increase compared to general population. In evaluation of rheumatoid arthritis, history and physical examination play an important role in looking at the disease characteristics. Special attention is given to the examination of peripheral joints, which are followed up subsequently after treatment initiation. A serologic test called rheumatoid factor is present in 75 to 80% of cases. Presence of rheumatoid factor correlates with presence of ocular manifestations and rheumatoid nodules on skin. Rheumatoid factor, however, lacks specificity and can be positive in up to 10 to 20% of non-RA individuals. Other assays include anti-citrullinated cyclic polypeptide antibody, or anti-CCP antibody, which has higher specificity compared to rheumatoid factor and has same sensitivity. Detection of anti-CCP antibodies is helpful in early rheumatoid arthritis disease, and it is usually associated with aggressive disease. Other tests include erythrocyte sedimentation rate and C-reactive protein to look at disease activity, synovial fluid analysis to rule out crystal arthropathies, X-rays in rheumatoid arthritis may show juxta-articular osteopenia, joint space narrowing, and marginal erosions. In patients with rheumatoid arthritis, a chest X-ray should also be obtained to rule out pulmonary manifestations of the disease. In the diagnosis of rheumatoid arthritis, a criteria called EULAR or ACR criteria is used. This was updated in 2010. EULAR stands for European League Against Rheumatism. ACR is American College of Rheumatology. Under this criteria, 4 characteristics are studied. The first one is joint involvement. The second is serology. The third being acute phase reactants. And a fourth, that is chronicity. In joint involvement, if one large joint is involved, the score is 0. If 2 to 10 large joints are involved, the score is 1. If 1 to 3 small joints are involved, the score is 2. If 4 to 10 small joints are involved, then the score is 3. And overall, if more than 10 joints are involved with at least one small joint involvement, the score is 5. Under serology, rheumatoid factor and CCP are assessed. If both are negative, the score is 0. If there is weak positive rheumatoid factor or CCP antibodies, then the score is 2. If there is strong positivity in rheumatoid factor or CCP antibody, then the score is 3. In acute phase reactants, ESR and CRP are assessed. In a normal ESR or CRP, the score is 0. And if the ESR or CRP is abnormal, that is, it is increased, then the score is 1. In chronicity, the duration of illness less than 6 weeks confers a score of 0. If the duration is more than 6 weeks, then the score is 1. Once this is calculated, the total score is obtained, and a score of more than or equal to 6 out of 10 is considered definite rheumatoid arthritis. Now let's look at the differentials of rheumatoid arthritis. These include gout, SLE, psoriatic arthritis, infective arthritis, osteoarthritis, spondyloarthritis, sarcoidosis, polymyalgia rheumatica. Now let's touch upon the treatment for rheumatoid arthritis. The goals of treatment or goals of therapy in these patients is to alleviate pain, reduce inflammation, maintain or improve functionality of the joints, prevent long-term damage to the joints, and reduce the non-articular manifestations, that is systemic manifestations of disease. Patient should be educated on the disease and should be told regarding joint protection, physical therapy, and occupational therapy should be done to preserve joint mobility. For this, assistive devices can also be used. Aspirin or NSAIDs are used in short courses to reduce acute flares and limit inflammation. Intralesional glucocorticoids or intralesional steroids are used in cases of single or oligoarthritis. Systemic glucocorticoids form the mainstay of initial therapy, especially until disease-modifying anti-rheumatic drugs take effect. Disease-modifying anti-rheumatic drugs include methotrexate, leflunomide, hydroxychloroquine, sulfasalazine, etc. Tumor necrosis factor inhibitors are also used in treatment of rheumatoid arthritis. These include etanercept, golimumab, infliximab, adalimumab, and certolizumab. TNF inhibitors are known to improve long-term complications and help in disease control, but these agents increase the risk of serious infections. Abatacept, which is a TCLA4 immunoglobulin, inhibits T cell activation, and this can be used in rheumatoid arthritis with or without methotrexate. Rituximab, which is an anti-CD20 B cell depleting monoclonal antibody, can also be used. IL-6 receptor antagonists, including sarilumab and tocilizumab, are also used. They help in reducing the symptoms in acute phase, which mainly occurs due to the effect of interleukin 6. JAK inhibitors, which can be used orally, include baricitinib, which inhibits JAK 1 and 2, tofacitinib, which inhibits JAK 1 and 3, can also be used. Interleukin 1 receptor antagonist, which is anakinra, was used earlier. Now it has a limited role due to very low efficacy. In patients with chronic deformities, they can be subjected to orthopedic surgeries and corrective surgeries.